Good morning, ladies and gentlemen. I'm Che, working for Seoul National University Hospital. My co-chair is Robert Brisin, and would like to start the live case session second, so from Severance Hospital. Before the starting the case 3-4, we first from Jae-won Lee, he will explain his case. Dr. Lee?
Yeah. Hi. I finished the procedures. Can you see the angiogram on the screen?
Yes, I can see.
Okay, this is the final angiogram we transferred, and this is an intra-stent angiogram taken by aspiration catheter. Next. So the thrombus mainly filled with the distal portion. Next. So I did several times of J-stream atherectomy more. Next, till the mid portion, P2 region of the pulmonary artery, because the native artery has also a moderate flux, so I did J-stream atherectomy. Next. Then this is the following angiogram. Flow was obtained next, gained, and distal landing was unclear, so I did next. I did aspiration one more time. Next, then I did angiogram at the level of the P2 level with aspiration catheter. The flow is good. Next, so I did DCB angioplasty for the distal from the pulmonary to proximal septate using 3 Lutonix DCB balloon from the P2 level with a native portion. Next. So next, 3 consecutive DCB, 5, 6 millimeters. Next. Then this is following angiogram. There's a slow flow. Next. So I did intra-regional angiogram again. Then next. Then I do several times of aspiration. Next. Then flow was obtained again. So I removed the filter device. Next. Then this is the final angiogram at the level of the distal pulmonary. Next, proximal distal, there is no distal embolization. Next, and proximal septate was also were opened. So this is the final angiogram.
Okay, thank you. We also have distinguished panelists from all over the world. So is there any comment? Okay. So we will start case number 3. So Dr. Ko?
No. So we are, yeah.
Dr. An.
Yeah.
Okay.
Here.
Yeah, we can see you. So please explain
yes,
your
good morning.
team. Yeah.
Very good. So Dr. Kishore was the first operator, and then I present our cases, and then my right side was Dr. Kim, our third grade fellows. And let me introduce our cases. It's a very interesting cases for iliac artery occlusion cases. So next slide. So 77-year-old male with intermittent claudications with the Rutherford class 3, and actually he received the interventions in 2012 in left common iliac to the external iliac artery with the stentings, and he had also diabetes and chronic obstructive pulmonary disease. Next slide. The ankle brachial index was decreased in the left side of 0.65. Next. So previous 2012 stentings was the common iliac to the external iliac crossover. So it's Palmagenesis 8/28 the balloon expandable stenting. So it's a very usual procedures. So next slide. So recently aggravated intermittent claudications, and we performed the CT scan, had shown some total occlusions of the proximal osteums of the left common iliac, and then the distal external iliac to the common femoral side. So it's our cases, and but CT scan shows that stent 좀 보여주세요. The stent proximal portion had proximal, yeah, had some the elliptical shapes and some kind of some compressed morphology. So it's a very unusual morphology of the stent. So we have so many points of discussions for these cases.
So, panelists and person.
So, Dr. Bob Burson here, it's a great case for you to demonstrate. First thing I note, 6 years after the initial implant, the degree of atherosclerosis has progressed in the aorta and the contralateral iliac. And so that suggests that this patient has a very aggressive atherosclerotic process. I wonder if he's a continuing smoker, for example. Stent compression, it could be that the stent was always elliptical. It wasn't really fully expanded at the time of the original implantation. And I saw quite a bit of calcification where it was not completely expanded previously. So it could be that this was partially lack of complete expansion on initial deployment 6 years ago. And maybe there was some additional element of extrinsic compression from the calcium subsequently. Yeah. But that being said, now you're dealing with a much longer occlusion segment in an ISR Tosaka C, occlusion here. So I think the strategy, at least from my standpoint, is to recanalize and then probably apply a covered stent with higher radial force. That would be my approach anyway. Yeah, panelists, other panelists, before he moves on to his intervention, other comments?
I would consider intervention of the right ostium iliac as well, because if we can see there is already some moderate stenosis of that segment. So probably a kissing stent, and I agree it should be a high radial force stent.
Okay, great. Yes, kissing stent at the bifurcation because of the progression on the contralateral iliac. Other comments?
We see a obvious compression of the stent. So do you plan to do the subintimal in this case, or you try to do the true lumen?
Dr. An, Dr. Sunarayan here. Dr. An and I discussed the case prior to starting, and we both agreed that we would try and go to the lumen. Luckily for us, when you look at the CT scan, the stent is actually across the orifice of the internal. So the distal end is available via the external quite easily, and you don't have to negotiate the bifurcation to get to the occlusion, which often, as you know, because of the anterior angulation, can be difficult, and you could easily end up subintimally. And we, as the first speaker said, we were quite content once we had crossed the lesion to do a covered stent deployment of the common and the external. We did notice, as you did, that the common iliac on the right side has disease. We are hoping not to interfere with that today, but occasionally, as you probably all well aware, when you do interfere with the common iliac on the left side, you can compromise or potentially compromise the right side, and you may end up having to do kissing stents. But that's not the original plan that we have in mind. Okay. What do you think? Is that you agree, Dr. Khan?
Okay. So, right side was a little saved, and then the perfusion was not bad. So I think that we put the left side plan was proper for these cases. But if there are some compromise or some mismatch for some the proximal lesions, so we had some restored the eyesight also. So how about the plan for some wiring initials? How about the approaches and the recommendations from panelists?
Dr. Kishore? Well, we had discussed it, and because of the potential, as there was no obvious stump in the left common iliac, the need for access via the brachial may be needed. So we elected to prepare both groins as well as the brachial to allow antegrade passage of a wire if necessary. However, our first approach was always to come from the left side and go retrogradely and see if we can cross the lesion easily, and use the right side access to demonstrate the anatomy with repeated angiography to locate the orifice of the right common iliac and also where the occlusion starts on the left side and the return of the flow into the distal external iliac artery.
I think that's a good strategy. That's the way I would approach it too. I would keep your control angiographic catheter across the common iliac lesion on the right up in the distal aorta. So if you do get any plaque shift as you work, you have it protected, and you can always stent the right common iliac as needed. And I would start retrograde as you have outlined.
Okay. So this is where we started.
So right side angiograms first. We performed the right side was puncture side was okay, and then right common iliac had a little diseased portions, but the pressure was not bad. So next slide, next. So it's initial angiogram from contralateral for the joking light. So there are stump at the left common iliac ostium, but the total occlusion was noted. So next slide. Okay, so we ultrasound guided punctures was performed at the left side the common femoral artery, and the angiogram shows the total occlusions of the common femoral to extrailiac junctions. Okay, so there are some stump at the proximal and distal. So,
which from our point of view we thought was very positive, because the presence of a stump at the common iliac, the success rate of crossing it is much higher than if it's a blind end. And also the stump in the distal external allows us to park a sheath quite comfortably without it falling out of the groin and still being able to access the common femoral artery. So there are some anatomical features which makes this case very conducive to a retrograde approach.
okay, next. So Dr. Kish, oh,
That was quick.
Yeah, well, Dr. An did this very marvelous job here. I was only directed.
So Dr. Kishore had some wiring trial first at the left side. So it's supported by the glide catheter with a routine thermal wire, and it's a little barrier was noted, but there's a very smoothly
Nice.
advanced the catheter.
So I'm sorry, was that a glide wire or what did you, what wire?
Yeah, it's a thermal J wire.
It's a soft glide wire.
With
Yeah,
a
sure.
glider catheter supported.
So basically a
Next.
looped approach almost.
So we checked the angiogram and hemodynamics. It's a very good penetrations, and we check IVUS from the common iliac to the external iliac for some visualized the stent morphology. Initially, we checked in CT scan. So IVUS 보여주세요. Yeah.
Very nice. I
So-
was going to suggest IVUS
So-
also.
So okay.
I just wondered if I could ask the panel, how many of them would routinely use an IVUS for a case like this?
For ISR and stent occlusions, I do.
But we did not perform usually for some iliac regions, but usually the SFA or some the other thrombotic regions. But for live demonstrations, we check the IVUS for this stent, and then we provide. So it's a stent area had a not bad compared to the CT scan. It's a little widely opened, and then the not the severely compressed area. So,
It went by quickly. I don't know if you can
yeah,
freeze on it
아까
and show us again.
스텐트 보여준 거 한번 다시.
We
Here.
repeated it again just for the area of the stent.
Yeah, good.
So it's a little same areas of the internal iliac artery was bifurcated. So it's a area. Yeah, it's this area. It's a most severely elliptical shapes of the stent, but it's not compressed. So initially the moderate shows says it's a very expansion is not good initially. Maybe it's due to the calcified plaques. So I think it's proper for some descriptions of these regions. And then common iliac region was progressed, and then the patient was symptom was aggravated. I think that is a natural course of this patient.
There is some compression and collapse. It's not fully expanded everywhere. But importantly, what this also shows you is that you're not going through side struts. You're within the lumen of the stent throughout. From a safety standpoint, I think you're now going to be very comfortable dilating and restenting this. If you're outside, I think your risk of vessel rupture increases. And then if you're through a side strut of the stent, you're in big trouble if you expand a stent through the struts of another one. So this was, I think, very useful to do.
Yeah.
Okay. So we wondered what their thoughts were on dealing with the lesion. Now, we've already used a 3 millimeter balloon because when we tried to exchange a 014 command wire for the 035 to potentially put the covered stent in, we couldn't get the glide catheter through, so we had to pre-dilate the lumen over the 014 and then replace the 014 with what looks like a Rosen wire, slightly stiffer wire than the soft glide wire.
So, so how about just balloons, or so we
Dr. Kishore,
prepare for the thrombotic embolization of these lesions, or some the other things we consider to procedure?
Dr. Kishore, would you show
Yes.
me the another angle? I recommend the RAO image. RAO image more than 30 degree. RAO
You want
image for left common iliac artery.
LAO 30 degrees?
Yes, I want to.
See that the stent, you're inside the stent?
Yes,
You
yes.
want to see
yeah.
the stent images?
Yes, yes. This image is RAO.
Yeah,
Yes,
RAO,
RAO, yes.
Another LAO image.
You want LAO?
LAO.
It's RAO.
Yes, it is no problem.
Yeah,
But
so I think that the IBUS shows that there are some
Yes,
not.
but I recommend it would be better to prepare the graft stent.
Yeah.
I think you should more fully dilate the previous stent. You know, you learn a lot that way. Not only do you make room for the covered stent, but you make sure that you can expand and that you're not going to have any issue. You know, you raised I think, an important question about how to protect the distal runoff bed from thromboemboli in this situation. And this is a difficult technical issue because here you've crossed retrograde, and it's hard to apply any sort of embolic protection from the ipsilateral side when you go retrograde. You know, you could go up and over now and sort of connect the dots and, you know, snare a wire and pass through from up and over, but that's complicated. And then recovery of your embolic protection filter is also complicated going up and over. That would mean coming down from the brachial approach, and now you have a third access, and it's, you know, it's technically challenging. So I've found it difficult to protect the distal bed in these cases, but often you get away with it anyway. You dilate enough to make sure you make room, you put in the covered stent, and a lot of times you're okay.
Okay. So
Most of
I
the
think I
time.
would agree with that.
7.
7 balloon, yeah. The stent that was used before was an 8x29, so we're electing to use a 7 millimeter balloon. As suggested, we're going to pre-dilate the lumen to allow the covered stent to pass through. Now, if the covered stent doesn't want to go through, we would use a longer 7 French sheet, which will cross the lesion to protect the stent along its way.
So we first dilated lesions at 7 by 40 millimeter balloons.
You know, as he's working, remember, stent retention of covered stents on balloons is not quite as secure as bare stents because the fabric doesn't, you know, gets in the way of the struts adhering to the balloon material. So slippage has been observed to be a little bit more of an issue with covered stents than bare stents. So you want to make sure you have a clear path for delivery and you don't catch on anything because you can have stent slippage with covered stents.
You could see that impression that there was some wasting at the transition between the common and the external,
Yeah, what pressure are you at?
Okay.
and it's now opened it up fully.
Okay. See.
I can actually feel it, as the previous operator said,
See.
you can hear things, you can see things, and feel things. So in this case, I am holding on to the balloon while Dr. Ann dilated it, and I can actually feel when the lesion was opened up a bit more aggressively.
When you make the retrograded approach and proximal end of a stent and the proximal stent is sometimes wire ride in the subintimal space. So we are careful about the proximal cap.
The other thing that we are noticing here while we are doing this is we are ensuring that the balloon is not deforming the stent while we're inflating it. Confirming what the IVUS has said and the RAO and LAO confirmed earlier on that the wire is in the central lumen of the stent rather than through the struts.
Okay. 4.
Okay.
Yeah.
The external iliac on your retrograde sheathgram was relatively small. I'm sure it's underperfused and in reality is larger, but you know, I'm typically pretty careful down here to not overdilate since it's been underperfused for quite a long time.
So often, as you said, it is underperfused, but we did look at a CT scan with a view to getting some idea of the diameters that we may need. And the 7mm balloon is also an indication of what size stents we may consider to place in both the common and the external iliac artery.
Good.
We will be planning to use 2 different size stents.
Okay.
Yep.
So there you go. You do have some probable distal embolization. I don't know if it's dissection or emboli. It looks like an embolus distally.
So,
Not quite sure, but
yeah, some haziness at the proximal side.
on the proximal side, yep, you know.
So we the stent cut.
You want to put a stent in? So you're going to stent the common left side and see what happens, and then we do the right side if necessary? We're going to do it simultaneously.
Left side also.
We're just discussing whether, so we're considering putting the left side stents first, and then we will have a look at the right side to see if there's an issue there that needs correcting at the same time. So what length do you think we need and size we need for the top end?
I think that the longer stent was needed for these reasons.
What diameter?
So 8.
8?
So previously stent
Use the
was
8 by 27, 29.
Yeah, 8.
So
I
you want
think-
to 8 by, you want to measure with the balloon or?
오케이. 지금 라이브 스트림이 몇 미리까지 있죠? 8에? 그게 제일 큰 건가?
So you're just deciding on the length of the covered stent we're going to use for the
So-
common and the external.
예. 58 was longer.
Right.
Yeah.
Will you measure the
Same
diameter
is-
by the IVUS? Or just
There's
by
a
the
suggestion
angiogram?
from the audience to measure the.
I
몇
think
미리지?
I recommend the oversizing stent graft would be better, more than 50% over 20% graft stent, oversizing
So
graft
outside
stent.
one.
You know, seeing this, my opinion would be take care of that distal portion first, go distal to proximal, because you have slow flow and a lot of intimal disruption. It
Yes.
goes about halfway down the sheath.
From what happens
And you
there.
need to tack that to make sure that nothing embolizes or that the dissection doesn't extend before you finish proximally. From a safety standpoint, I would do the distal first, and then the proximal is no issue after that. That technically could be more of a challenge for you, I don't know, because it's so close to the sheath, you have to retract the sheath and so forth.
Okay, so you want to run there again?
I would take care of distal first.
Okay,
Yeah.
have to go. You want to do a DSA or?
DSA?
Okay, so if we mark the spot there
Yeah.
where the external is,
So it looks like you have to go about 3 centimeters, 2 to 3 centimeters distal to the tip of the sheath.
yes. So could you put a little mark on the screen? And what size stent, do you think we put a 7 in the external?
Yeah. 7.
All right.
8.
Eight in the external?
I would say if you got 7 by CT with it occluded, I would go 1 millimeter larger and
the
use an 8.
이거 어디?
So
1, 2,
8 by 59,
디스탈.
the distal end?
Yeah, yes, I would go 1 millimeter larger because it's been underperfused and the 7 millimeter by
2, 3,
CT
4,
is with an occluded vessel.
Yeah, 7.2 millimeter in IVUS, the distal external iliac to confemoral junctions.
Good, 8 millimeter self-expanding then.
Yeah, 8, 7.
We're going to use a
Yeah.
balloon expandable stent.
You're getting pretty distal there. I would use self-expanding.
Self-expandable to the just the distal to the stent, and then we proximal to the stent graft.
And you want to do a balloon expandable after that?
Yeah.
Covered stent. We don't have a self-expanding.
Self-expandable in the external ileum.
Yeah, you could use a covered stent for the ISR and then self-expanding for the external.
Yeah.
Okay. So what? 8?
88에
No, that's a covered stent.
아니 그거 말고.
So I understand the other room is ready to show us what they're doing. While you're working away with your stenting, we'll go to the other room and then come back. How does that
Marvelous.
sound?
Well done.
All right.
Yeah.
Thank you. We'll be back.
Okay.
Okay, Dr. Go.
Okay, good morning. I'm Young-Guk Ko. Good morning, everybody. I would like to introduce our team. I'm Young-Guk Ko from Severance Hospital. On my right side, Dr. Sang-Won Shin from Ilsan National Insurance Hospital, and Dr. Yoon-Jung Lee is our fellow, so she's assisting our case. So let us introduce our case. Dr. Shin?
Good morning, everyone. I'll introduce our case. This patient is a 75-year-old male, and he had diagnosed the abdominal aortic aneurysm. He had no symptom, but he was diagnosed during the prostate cancer evaluation. He also have old CVA, moderate mild CKD, hypertension, dyslipidemia. Next. As you see in the CT imaging, in the renal artery region, there is a 25 millimeter length, and click, yeah, and there is a 51 millimeter of abdominal aortic aneurysm in the infrarenal area. Next. Next. In the volume rendering imaging, you can see the relatively long common iliac artery, more than 40 millimeter, and he also have long neck areas, and there is a little angle, but it can be suitable for the endovascular intervention.
Okay.
Next.
Yeah. So back, please. Okay. So basically, this patient has asymptomatic AAA. Back. And the size was to 51 millimeter. So we actually said to urologist to to go ahead with the prostate cancer operation, but they wanted to do our treatment first for the AAA. So this case is actually a relatively straightforward case, except for some mild angulation at the aortic neck. So actually, in Asian countries, patients usually don't have long common iliac arteries, but this patient has common iliac arteries longer than 40 millimeter. So I think this is a good case to demonstrate the AFX2 endologics device, and also there is the proximal mild to moderate angulation. So I think in this case we can demonstrate the AFX2, and we have this device since summer last year. But at the time, so far until now, we have only proximal extension endograft for the proximal part. But today we can use the Vela proximal endograft. So we'd like to demonstrate this device for the audience.
Okay, Dr. Go.
Any question about the
Dr. Go.
case?
This patient
Yes.
has more than 30 and 46 millimeters of common iliac artery length. So regarding use of AFX2, so what is the minimum length of the common iliac artery landing zone?
Yeah, usually the minimum length is 30 millimeter. So, but this patient has the longer common iliac artery. Could you click the slide? Forward. So we'd like to use the AFX2 device. This is a unique. This device has a unique design. This is a unibody bifurcated stent graft, and we can implant then on top of the bifurcated stent graft the proximal endograft. So this is a two-piece system. And next, okay, this is the delivery system. The main body is delivered by 17 French compatible device. It has 19 French out diameter. And on the left side, we can use just 6 or 7 French sheaths. Next slide. And it has a very unique design. It has no suprarenal or the infrarenal fixation, but just anatomical fixation on top of the natural bifurcation. Next. And next. And so since it sits on the natural bifurcation, it does not require renal level fixation. Next. And it has also active sealing. So that means the graft is sutured only at the proximal edge of the stent graft. And so if it is deployed in the infrarenal area, the graft just seals the gap between the aorta and the metal struts. Next. Okay. And Vela system has a more visibility of the proximal endograft, so it is we can better control the level of the stent graft. Next. And this is the proximal extension endograft which was used previously. Now, next, we have the Vela proximal stent graft. It controls better the position of the proximal endograft. So I think we have a now better device to treat the AAA. So I have here AFX2 device. So this is the bifurcated stent graft. It's loaded in this caster, and it has a yellow caster with a wire. So we will insert this device through the sheath, and then we will capture the wire inserted in the yellow caster with the snare from the contralateral side, and then we will pull out the contralateral side into the common iliac artery. So in this manner, we will position the bifurcated stent graft on the natural the bifurcation position. Okay.
Okay, so while he's working away, I see this as a well-indicated case. It's an aneurysm between 5 and 5.5 centimeters, which is the ideal size range to treat with an endograft. The outcomes databases, both Lifeline and then the Eurostar, clearly demonstrated that endograft performance is related best, as far as aneurysm rupture-free survival, is best correlated with the size of the aneurysm at the time it is treated, being between 5 and 5.5, having better outcomes than when it's larger. This has also just one, I would say, relatively adverse feature, that being an angulated neck. Does not have multiple adverse features, and appears to be within the IFU of the device. As we know, endograft performance is also affected by whether you are treating anatomy that is outside the IFU rather than inside the IFU. Okay. And this, I think, falls well within the IFU of the device. So you have the right size, you have the right anatomy, and it's within IFU, so I think it's an indicated case. It's a good case to do. Now you can pick and choose which device you want to apply. I think this device should perform perfectly well in this scenario, but there's a variety of devices you could choose because your neck is long. You have a 40+ millimeter long neck, so I think it's dealer's choice as far as which graft to apply. This one appears to be perfectly fine as far as being indicated for this case. So I see this as well indicated and a decent choice of device to apply.
Okay. So I captured the wire from the contralateral side with a snare.
Well, you've also shown us how easy that is. That went pretty quickly. Okay. What size snare did you use? 20 millimeter or even bigger?
45.
45
millimeter, yeah.
Giant size. Okay.
Yes. It has 3 loops, so it is very easy to capture the wire.
So it's tri-lobe. End snare 45. Okay, so we are inserting. So for the audience's benefit, that's done first because that's your contralateral limb. It's attached to that yellow wire that was snared. And the operators just have to be careful not to twist and rotate and wrap that yellow wire to make sure orientation is maintained in the AP plane.
Okay. So while I'm pushing up the bifurcated stent graft into the aorta, so my cooperator is pulling out the wire attached to the contralateral limb. So I will rotate whole device.
Now here, because of neck angulation, you're going to lose length as you go. You know, but you're building from the bottom up, so this is not a bad device to apply. You know, you're seating at the bottom, bifurcation, and then you can make your final positioning of your extension graft with plenty of overlap. It looks like this is a 100 millimeter length bifurcate, and then you have a 100 millimeter length extension aortic cuff. That should be plenty of length, you know, even though you're going to lose quite a bit, it should be plenty.
So I think the device is just on the natural bifurcation.
Mm-hmm.
좀 더 위로. Okay. So, yeah. Okay. So I'm going to deploy the bifurcated stent graft by pulling a thread here.
Just putting traction on it.
Yeah. Okay. Okay. Can you see here? Okay. 뭐 있나? 막을 거? And then we'll deploy the contralateral limb.
Notice how he's pulling on the limb to make sure it gets fully extended and not kinked.
당겨주세요. 당겨줘요. Okay. So yeah. Okay. So the contralateral side is now deployed. We are going to insert the pigtail to remove this the wire in the contralateral side. So the connection of the wire is the connector is directed into the upward direction. So we use a pigtail caster to detach the wire from the connector.
Yeah, that limb doesn't really look fully expanded yet, so hopefully it'll pass up without too much trouble.
Mm-hmm.
Yeah, you can see it's kind of compressed there. There you go, you made it.
Zoom 해볼까요? One, two. Okay, we'll magnify the image. So now, using pigtail device, we change the direction. Now, it sometimes manipulation a little bit. Doesn't come out. Do you have any tip?
Dr. Go, please
Yeah.
change the angle. 알아요.
Yeah.
or,
알아요? Okay. 요거를?
we have to confirm the pigtail tip is fully attached to the connector.
바꿔볼까?
Okay.
앵글을 좀 바꿔볼 수 있어요?
저건 더 겹치는데 더 쪽으로 줄게요.
어떻게? Okay.
Okay.
Now detached.
Yeah.
Yeah. Okay.
Fine.
So, okay, 테르모.
So the pigtail looked like it clearly went outside the shadow of the frame, huh? Is it
Yes.
outside? Yes.
Actually, not outside.
It looked like it deviated way out.
Okay. 오케이. 자, 이거 뺄게요. 오케이. So, 요걸 끝까지 좀 빼줘요.
어디요?
네. 저항이 다.
Okay, so the delivery system's coming out,
오케이.
and the pigtail's up. I take it the delivery wire for the control has been disconnected now?
So the bifurcated stent graft is now fully deployed.
Yep.
And we will insert the proximal endograft. So Vela device, please. So we'll take a 34 millimeter in diameter for the proximal part.
You know, the only comment I'll make is it looks like the common iliacs are kind of small and they're calcified and the graft isn't really fully expanded. I hope the 34 will pass through there without any trouble. You may want to dilate the iliac beforehand just to make sure you have room. That's up to you.
Yeah, we will try first and see whether
Okay.
we have the resistance.
If it doesn't go, then you'll have to dilate.
다이레이터를 먼저.
Dilator. Okay. So we have to reposition the sheath. So we will bring the sheath upward
Right, and then probably
at the
redo.
level of the renal artery.
Make sure to redo your angiogram to get your positioning.
Okay. Yeah. So there is not much resistance while I'm pushing up the sheath. Okay. How about this level? Okay. 좀 더 올라갈까요? 오케이. 자, 이거 좀 빼고. 오케이, 그래서 실상했으니까 됐어요. 오케이. 자, 엔조를 하나 좀 찍을까요?
앵글을 좀 더 줄까요?
오케이, we'll take a picture now.
Good.
오케이. 줌 하나 빼고, 오케이, 여기다 합시다.
여기 다시.
오케이, 엔조. Okay. The right renal artery is positioned a little bit lower than the left side.
Just slightly, yes. We see that.
And I think, okay, so we will go up a little bit higher with the whole device. Yeah, so it has the bare metal, the portion, and the next marker, the second marker is to indicate, it is graft, the beginning of the graft.
Now,
Okay? So the level of the graft is a little bit, so maybe 1 centimeter higher than right renal artery ostium.
Yeah. Do you still have the stiff wire in?
Pardon?
Do you still have a stiff wire in on the delivery
Yes,
system?
yes.
Yeah, you may, since it's tortuous neck anatomy, you may want to pull that back, and that'll help the graft tilt anatomically in the correct direction with the with the right side down to the lower right renal. Might help.
Yeah, but in this case, this patient does not have severe angulation. I think we'll go like this, okay? So the distal part of the vela stent graft is now a little bit deployed, but still the proximal part is held by the system. So
yes.
now we will adjust okay, here still I will have the graft level above the right renal artery, and then I will try to deploy the proximal part, okay, by rotating here the deploy mechanism like this.
Yeah, see the right side tilted down to go with the neck, which is good.
Okay, but the distal part is still is held by the delivery system. So even though the proximal part is already deployed, so I can bring the stent graft down to the level where I want. Okay, so now I will change the angulation of the fluoroscope to have the proximal.
Take out the parallax.
Yeah, do you see the kind of the ring figure? It has a more wave-like figure, but anyway, it has a marker at the proximal part. So we'll take a picture, and then we'll find the level of the right renal artery ostium. Okay. Okay. So maybe
Come
1
down
centimeter.
a little, huh?
Yeah. So I'll bring the whole system a bit downwards.
Okay, that's
That's
Yeah,
good. Maybe take
so-
another shot. huh?
Okay.
Another picture.
I think this. Okay, and then
Here
okay, it went up a little bit. Okay. So I then deploy the distal part of the.
Do you want to take another picture first, just to be sure?
Okay. Yeah.
Make the audience happy.
Okay, Cine.
Yeah, that looks good.
Yeah.
Looks
Yeah.
good. huh?
Okay. So
Professor
I
Cole?
deploy the distal part.
Professor Cole?
Yes.
The suprarenal hook is fully open right now, right?
Yes.
Yes.
So is it possible to injure the aorta wall?
So this hook, actually there is no bar fixation, in the proximal bare metal, the struts. So it is not fixed. So we can still bring down the stent graft while it is already deployed.
Can you give us a quick angiogram to see how it looks? It may be sealed just with the active fixation already. In which case, then we would go back to the other room to see the completion of the other.
Then, yeah. subsection. 제 소리 들리세요? 예. 제가 숨 참으세요 하면 숨 참으세요. 예. 예.
그냥 찍어보자고 하죠.
그냥 찍는다. 급하게 빨리 찍어야 되니까. 자, 숨 들여 마시고 숨 참으세요. Yeah, it looks nice.
Looks good. You know, you still have you know, this will go away, but you can balloon it, but you have a little leak around where it's bulbous in the neck, but you have a minimal, it is showing up in the distal sac, but I'm sure as you balloon it or fully expand it, it should be okay.
I mean, you see the space filled with conjunctiva at just the level of below the renal artery. It is not endoleak, but it is still within the graft.
Right.
So this is the active sealing. So proximal part of the graft is fixed, attached to the metal, this stent, but the distal part is not attached. So
no, I see that. I see that.
Yeah,
but,
it is active sealing.
yeah, but down, if you look down at the iliac bifurcation, it's puddling quite a bit quickly. See that? So it's still getting around a little. So why don't we go back to the other room to see the completion of the iliac case, and then we'll come back to you for your final imaging. Okay? We'll come back in about 5-10 minutes.
Okay, we finalized the cases, and then the angio 보여주세요. Okay, after balloon, there are some haziness at the proximal portion of the stent, and then distal was also had a disease portion. So we put the stent, the bare metal, epic stent 8 by the 80 millimeter. So balloon self-expandable stent, and then we pose the balloons by the 7 by the 40 millimeter. And after balloon, there are balloon하고 엔지오. 예. So okay. So after the self-expanded stent, we measured the 40 millimeter balloon for some exact site of the live stream stent graft, the proximal portion of the left common iliac ostium. So we have a landmark for the lower portion of the vertebra. So we put the stent, the 9 by the 59 millimeter live stream, and balloons. And after that, we check the angiogram for right side and left side. Sheath angiogram shows the very exact positions of stent. And then next angio. So there are no distal embolizations of the confemoral and then popliteal artery. So there are no symptoms and very good distal pulse. And then we did not perform the additional procedure for light common iliac artery. There are no pressure gradient, so we keep the procedures. So
final IVUS, did you check final IVUS? Because this patient has critical stenosis even in the first intervention. So that's why the reason the restenosis and the elliptical portion. So did you check the? No.
Did you high pressure post dilate also? Because you know there's still some at the point of original stent occlusion. It's still a little not quite fully expanded.
Yeah.
And you know, did you go with a high pressure non-compliant to fully expand it after deployment of the live stream?
So.
No, we didn't. We just used the normal live stream, the balloon that accompanies the live stream stent, and initially dilated to the nominal pressure without causing harm to the external, and then we dilated to the burst pressure in the common iliac. And we didn't think on the views that we did, this is only one of the views that you're seeing, that there's any significant compression to warrant any more active higher pressure balloon use. And with the normal pressure waveform and the pressure measurements on the sheath, we elected not to do the IVUS. Although it was already there, we could have used it. You're quite correct.
So initial IVUS shows had a common iliac ostium to the proximal portion of stent. Diameter was 9 by 8.3. So I think that we put the stent, the nominal pressure of the live stream is sufficient for this patient of the position. And then another thing was we consider is there are some chance of the thrombotic portion of the proximal portion. So I think that the high pressure was a little the chance of the right side or left side distal embolization. So I think that the high pressure was not primary needed in these cases. So how about the panelists?
I personally would have high pressured it. It should be safe now and it's not fully expanded. Remember, and that was the point of failure before. So I would really fully expand that out. Since you're covered completely in that area, it should be perfectly safe to do at this point. You know, I can see how you got 9 millimeters at the ostium because it's not constrained there, but I can't imagine that you got 9 millimeters in the middle of that ISR lesion because the previous stent was 8 millimeters and your life stream is smaller than that. So it's looking like your MLD is 6 or 7 maybe in that area.
I'd just like to point out the live stream was actually 9 millimeters in diameter. The previous balloon expandable stent was 8 millimeters.
Yes.
So we actually expanded it larger than the previous stent.
Well, but your angiogram shows that you're smaller than the previous bare metal. So you must be smaller at that point.
Yeah, in the distal external iliac, the proximal external iliac, the stent that's there is an 8 millimeter previous stent, and the stent that was used is a similar size stent. So I'm not surprised it looks like it's actually inside the lumen of the previous stent, suggesting that it's not fully expanded. But that's a self-expanding stent, whereas the proximal stent is a balloon expandable stent.
Yeah, it's a great result. You know, I think you're to be congratulated for that. Okay. You know, what the correlation between MLD and patency of covered stents, we just don't know. Covered stents just don't behave the same way, but excellent outcome, and thank you very much. Now we're going to go back to the aortic theater to see how we turned out there. Okay.
Dr. Go?
You're back.
Okay, can you see us?
Yes.
Okay, so we have the final result. So please look at the angiogram. So what do you think?
I think it's a beautiful, great result.
Yes, I think so. If somebody has a little experience with this device, then he may think there is an endoleak, the proximal part, and the distal the aorta, but it is the active sealing, so it is within the graft, and I don't think there is so endoleak, at least in my eye. So I'm quite satisfied with the result. Do you think we need to dilate the iliac arteries? I'm not going to dilate, but I don't know. So there is at least no retrograde endoleak.
Yes.
So
Yes,
I think we can leave that. Yeah.
Yes, I agree with you because there is no endoleak from the distal part, and then also the iliac has a calcified disease, so the further balloon inflation may injure the iliac artery, and this is, I think, a great result from this device, using this device.
It's excellent positioning. I think you have good sealing proximally. There's still contrast filling distally, just above the aortic bifurcation on the left lateral wall of the aorta, but I can't tell if that's type 2 from a patent lumbar or where it's coming from, but it's not a large amount, and it doesn't appear to be proximal type 1. So I think I would conclude here, and with reversal of anticoagulation and active sealing, it should resolve. It looks like an excellent placement, great demonstration. Thank you.
Okay. Thank you.
Okay, thank you. So I'd like to close live session second. Thank you for joining us. Thank you.